to orient us all to the problem at hand, we've got this slide that we often show in our talks, and these numbers keep changing because the situation is not getting any better for the U.S., and that is that 6.7 million in the U.S. have Alzheimer's disease or presumed Alzheimer's disease. We think that about 14 million will get this by 2050. It's the 7th leading cause of death in the US, and the deaths increased by 146% relative to a decade ago, while other diseases like many cancers and heart disease are going down. As we get good at solving those diseases, Alzheimer's declares itself over time. And it also rarely occurs alone. There's often co-pathology that Jen alluded to. This idea of multi-etiology or mixed dementia is something I'll talk about later. And the important thing is that there's new treatments, and they're very effective at removing amyloid plaques from the brain. And that's a big deal. And Dr. Przybelski will be talking about that, I think. In Wisconsin, there's roughly 120,000 people that we think have Alzheimer's disease across our state. And as it is in the nation, it's the 7th leading cause of death here in Wisconsin too. Well, we're really trying to address this in an urgent way at the UW. We've got a really large and continuing to grow program. We have the Alzheimer's Research Center, led by Dr. Asana, and at the Alzheimer's Institute, we have the Wisconsin Registry for Alzheimer's Prevention. These are separate groups of subjects, but we often combine our data for analyses and try to confirm a finding observed in one cohort in the other cohort. So it's really a nice synergy and just a tremendous partnership that many of our investigators are enjoying. So here's where our participants live, and some of you may be participating in one of these studies. In this case, the purple dots are RAP, and the red dots are the ADRC clinical core. And you see there's clusters around Madison and a cluster of purple for RAP in La Crosse. And in Milwaukee, we've got a smattering of both, but more RAP participants. And that's because we have data collection sites in Milwaukee and in La Crosse. And we also have a cluster up there north of Green Bay in red. And that's because we have a really important presence in the Oneida Nation up there. And that's really been a really helpful and enlightening collaboration with the Oneida Nation. Okay, you've probably seen a slide like this before where we talk about Alzheimer's accumulating and changing over time or age. That's operational. That's the way we can think about time as age. And on the y-axis here, we have thinking abilities. And normally things go down a little as we age. But with Alzheimer's disease, especially as we get to the mild impairment and dementia stage, things really start to become noticeable. And dementia, the definition of dementia is really not being able to have the same mental capabilities that one used to have, to the point where it's impacting your ability to get around in your day-to-day world and to do the things that you used to do. But mild cognitive impairment is this in-between zone, and sometimes it progresses to dementia and sometimes it doesn't. But if we can head this disease off earlier and not let it take its natural course, we may be able to preserve things. And that's what these dotted lines are meant to depict. And we really want to try to pick up this disease back here when a person is aging normally, and that where that curve is not too different. The red curve and the black curve are not too different, and we can preserve function for longer. That's what we'd like to do. And I'm showing here a number of little biomarker modalities. We've got imaging there. We've got that clear fluid, which is coming out of the back. That's called cerebral spinal fluid. And then I've got a blood tube there. And all of these modalities, spinal fluid, blood, and imaging, are useful in telling us whether the AD proteins are there. So we really want to start early with this to avoid the calamity of Alzheimer's disease dementia. Well, how can we identify this disease? It's the neuropathologist sees these two things in the middle. They see amyloid plaques and they see neurofibrillary tangles. But this, for the neuropathologist to get involved, the person has to have passed away, and we can get a definitive diagnosis at that point. But we can do imaging in life, and we can actually do this many years before a person even has symptoms, and we can screen for this disease. We can tell if people have this disease, and it's these kinds of images here. One is an amyloid scan that looks for amyloid plaques, and the other is a tau scan that looks for neurofibrillary tangles. Tau is the protein involved in tangles. So this is really really freed us up to understand this disease early in life, and I want to show you what that looks like. But just so we're all clear on what this, how vivid these images can be, we see participant 1 here on the left, and there's their amyloid scan on the top and their tau scan, so the plaques and the tangles. The tau scan's on the bottom here, and then another participant on the right, their amyloid scan and their tau scans. You can see the difference here in the color, and especially the red color. There's no evidence of this red color on the person on the right because they don't have amyloid in their brain. They're negative for amyloid and they're negative for tau. They don't have Alzheimer's disease, but the person on the left does seem to meet the definition of Alzheimer's disease. They have both plaques and tangles. The interesting thing about these two people is that they both have mild cognitive impairment. In one case, it appears to be due to something other than Alzheimer's disease, but in the other case on the left, their mild impairment seems to be due to these proteins that we can now detect with imaging. So what I'm showing you here is basically a biomarker. These images are biomarkers of Alzheimer's disease. And the reason we call it a biomarker is because it's a marker or a test that tells us about a biological process in the brain. In this case, the biological process is plaques and tangles. Okay, let me go on to this slide. Well, why don't we just do an MRI? That's a lot easier, and those are available in more places in the state. And the reason is MRI is obviously, it's very useful for a lot of things, but it doesn't give us any information about plaques or tangles. It tells us if a person has vascular disease. And here's an example of that. This MRI on the left side is really fine-tuned towards ischemia or low blood flow in the brain. And these bright spots in the brain in the lower part of the image are areas where there's low blood flow or ischemia in the brain. So MRI is useful for vascular disease. It's useful for helping us understand the anatomy of the brain and for looking for structural abnormalities like certain kinds of tumors or vascular anomalies, but it's not good for picking up early Alzheimer's disease. Well, going back to those amyloid scans that I showed you, we've been doing this here at UW since 2009, 2010, really, I guess. And here's a snapshot of some of that. And what we see here is each of these dots is an amyloid scan measurement. And we can take that whole scan and condense it to a number, and we plotted that number here versus time. And if there's a repeated measurement, it's connected by a line. And that's why you see these lines here. That's a person with repeated measures over time. We've color-coded these red for the people who go above that dotted line, which is our threshold for being positive for amyloid, having affirmative evidence of amyloid in the brain. What we see here is that the rate of change over time is pretty similar. If you just eyeball those red lines on the left, the rate of change is pretty similar. What differs is the age of the age that a person is when they cross that dotted line. In some cases, if you presume that the rate of change is going to be the same for these people who only have one scan, and you just eyeball that back, we can use this as a way of estimating from a single scan when a person may have become amyloid positive. And we've done that here on the right side. We've actually fit a mathematical function to really put all these people on the same scale, even though their chronological age may be different. Some may be 50, some may be 70 when they did the scan. We can put them on an Alzheimer's age, so to speak, and get their time zero, the age at which they began their Alzheimer's journey, which is probably going to be 20 years or more before their symptoms. It's pretty remarkable what we can do. Well, we also, we've published this, and now it's been published by WashU down in St. Louis. They've shown the same thing with their amyloid scans. Our friends over at Mayo have shown the same kind of thing. They can fit a mathematical function to their longitudinal data and get an age of onset. Our colleagues in Baltimore at the Baltimore Longitudinal Study on Aging, BLSA, they've shown the same kind of thing. And some of the publicly available data sets, one's called ADNI, the Alzheimer's Neuroimaging Initiative, we can see the same thing. We can fit a function to this. And this means we can get an age of onset in a pretty reasonable way as an estimate of when a person began their Alzheimer's journey. Now, most of us will never get on this journey at all. It only affects about 10% of individuals over age 65. But we need to be able to have the tools to detect it and also know a little bit more about the temporality of this. When did it begin? How long has a person been on this journey? And when should we start intervening? What we see in this slide is that the average age that a person becomes amyloid positive, it's about 62. But that's where this thick line here is in the middle. But you can see that really no one is average. Everyone has their own unique onset age. And in some people, it's as early as their early 40s. And some people, it's as late as their mid 80s in this particular plot. We've now sampled more cases, and we see that age range goes well beyond age 85. But this is informative because it's telling us that this disease is beginning quite early in midlife for many people. And indeed, these people who are now coming to the clinic with dementia, those are the people in red, or people with MCI, they tended to get their amyloid earlier in life. And now, as they're coming to the clinic, maybe they're age 60 or 70 or 80 now, we can see that their disease began a long time ago. And that's reinforced here with this plot. What we're seeing on the x-axis is amyloid time, normalizing everybody to the age they were when their amyloid journey began. Again, this could be well before symptoms. And on the y-axis, we have this, what we call a CDR, a clinical dementia rating. And a clinical dementia rating is really just a rough tool to gauge how impaired is a person. And a rating of 0 is no impairment. And when the various categories or boxes that we use are summed and plotted here, we have different bands. We've got this very mild band, and then a mild dementia band in yellow, in orange, moderate, and severe in red. But what we see is that by the time a person gets on their amyloid journey at time 0, and we follow this blue line, which is the average line, up to mild impairment, which would be kind of a rough definition of mild dementia, it takes about 24 years to get to that point. And that gives us an incredible window of opportunity to identify this disease and intervene before it gets to that point. But we see here that this blue average line isn't really telling the whole story, is it? There's a lot of people here to the left of the blue average line that are reaching impairment much earlier than we would predict by the average. But then also there's people down here who've been on their amyloid journey, so to speak, for 25, 30 years, and they're not impaired yet. And they're only becoming impaired 20, 30 years into their amyloid journey. And so there's evidence of what we would call resilience or resistance to this disease. There's also evidence here to the left of the curve of susceptibility to the disease. And we looked at this a little bit further, and lo and behold, what we found is these people who are more susceptible to cognitive impairment, they had other things happening. They had vascular disease happening in their brain. And they were also older than the people who were showing this resilience characteristic. And so that's giving us a little bit of a clue that maybe there's not only vascular disease, but because they're older and still still undergoing the aging effects in the brain, there may be other diseases co-occurring. So we're gonna keep looking at that, and I'll get back to that in a second. But imaging is just one kind of marker. We now have other markers, including blood and spinal fluid, that we can use. And with our colleague Henrik Zetterberg, who's a visiting professor here at UW, he's perhaps the world's most recognized figure in biomarker research. We're really lucky to have him here at our university, but he's helped us with the idea of putting a blood sample onto a machine like this, which is an analyzer that can detect very, very subtle levels, very small levels of Alzheimer proteins in the blood. And we've been looking at that, and we find here in the RAP cohort, which is on the left here, we find that the people who we have some ground truth on from their amyloid and tau PET scans, we can see how the blood is performing. And indeed, the people who are amyloid negative or tau negative on their PET scans, those fancy images that I showed you earlier, they have very low levels in their blood. But their blood levels of Alzheimer proteins go up when in conjunction with their PET scan results. So the people in red here who were amyloid positive and tangle positive, tau positive, they have the highest levels on their blood test. We observed this also in a cohort from Canada called Triad. We observed this very same thing also in a cohort from Spain called the SPIN cohort. And we did some classical statistics on this to show that the accuracy is very similar across the world, whether it's in RAP or in here in Wisconsin or in Canada or in Spain. You can get very similar results with these blood tests. So this is very, very promising. We published this paper earlier this year, and it made headlines in Newsweek and Time Magazine and a few other places. You may have run across this. So blood tests are going to be the way of the future, and not everybody can come into a high-powered university like the University of Wisconsin and get these very fancy imaging tests. We need to be able to go out to the community, go out to rural areas or to underserved communities and make sure we can accurately detect this disease in those places too. So that's why we're really focused on getting blood tests for Alzheimer's disease. We want to make sure they're as good as the PET, this molecular imaging gold standard. We also want to get to the point where we can detect this disease in the community before there are symptoms, so that we can act in a proactive way and prevent this disease from ever occurring. And that's really our center's mission. We're still a long ways away from that, but we're very optimistic that we're onto something very good that's going to be a tool for the future to help us get there. Let me just show you an example of how this can work. And I need to add this person's blood test results, but this is an individual who is a woman. She didn't have the Alzheimer's risk gene called the ApoE gene you may have heard about. She was age 54 in RAP, and she was about 67 or 64 at her last RAP assessment. she's had 5 visits with the study, and she had a parent with AD. And we're looking here at her, where she fits on the amyloid timeline. She's way up here in this big circle. So we think she's had this disease. We think she's had it about 18 years at the time that this image was collected, and that she became amyloid positive at age 47. And we also see that she's elevated for tau signal on this. This is the fancy name for our tau scan. It's called MK6240. But anyway, she's got tau in her brain. She's got amyloid in her brain. But this particular person, up until this time, was cognitively normal on the memory tests that we do. And we're still, we're sort of watching and trying to learn from this person and people like her who have preserved function in the presence of this, what looks to be pretty serious proteinopathy in her brain. Well, just one more slide here. We have this new study that Jen referred to. It's called Clarity, the Consortium for Clarity in ADRD Research Through Imaging, and we put an I at the end for imaging. It's because this mixed etiologies as a cause of dementia is more common than pure Alzheimer's causing dementia. Things that can co-occur with Alzheimer's include vascular disease in the brain, what we're calling neuronal alpha-synuclein disease, which is the protein that causes Lewy body dementia and Parkinson's disease. Frontal temporal dementia is very common. I wouldn't say it's common. I'd say some of the proteins that we can detect with frontal temporal dementia those are common. And also a new entity that we're calling late, or it's limbic related age-associated TDP-43 encephalopathy. That's a fancy name for having this TDP-43 protein in the brain, which shows up in the same areas that Alzheimer's shows up in, and it can cause memory impairment and fool doctors into thinking that a person has Alzheimer's disease when in fact their disease is caused by this other protein, TDP-43. And why does that matter? It's because our current treatments for Alzheimer's aren't going to touch TDP-43. We can remove plaques, but if their cause of memory impairment is actually a different protein, then we're not treating that person with the right therapy. So we need biomarkers for these other things too. We're very good at detecting Alzheimer's. We're very good at detecting vascular disease. And we're on the cusp of having markers for these other proteinopathies that cause dementia and that can co-occur with Alzheimer's protein changes. So we'll be doing this across the country and enrolling 2,000 people and following them over time. And this study is, even though NIH awarded the money in fall of 23, we're still setting up the study and plan to get our first patient enrolled sometime later this spring. Well, let me just summarize that AD is detectable, AD being Alzheimer's, years before the symptoms with biomarkers. And I've showed you some examples of biomarkers with imaging and with blood. You can also do this with spinal fluid, and we continue to collect spinal fluid in our center. AD, this amyloid amyloid plaques can onset at ages from midlife into late life. But those onset ages are estimable now. We can detect and estimate when a person became Alzheimer's positive, what age they were at. And we also know that this amyloid protein, it grows very slowly, but predictably in the brain, and it's not benign. If you have it, chances are very good that you're going to go on to get tau. It may not happen. It may take 20 years to develop tau, but that's going to happen. And the longer a person has had amyloid, the more likely they are to exhibit cognitive decline. We know that lifestyle and health factors, I didn't talk a lot about that today, but those really they're so important for slowing down cognitive decline and keeping the brain healthy. We don't think they're influencing the rate of progression of amyloid or tau. in the brain, but they are certainly influencing synaptic health and neurons, or the nerve cells in the brain, keeping those healthy. Vascular disease is one way, and avoiding vascular disease is one way we keep those neurons healthy. And so we need to do that. We need to make sure we're having a healthy lifestyle and avoiding these vascular lesions, because those will impact cognitive decline too. And finally, blood markers are coming. They're here, in fact, and they can be ordered clinically. And they're going to be useful at getting Alzheimer's disease care to more people throughout the country, and getting it out of the large academic medical centers like UW. But that's kind of a vision for the future. We still need to treat this disease. Still, right now, these new therapies are only done in major academic medical centers. Well, let me stop there. I'll just acknowledge all the amazing people who helped make the center tick on a daily basis, and thank all of you for listening. And I can take any questions, Jen, if we have time, or if we need to stop, or if we need to wait till the end, that's fine too. You're on mute, Jen.
Oh, I think yeah, there you go.
Can you hear me now?
Yeah.
Thank you so much for presenting all of this information. It's really insightful, and there's a level of excitement that I feel in hearing what the future of being able to deal with these cognitive changes might look like in a clinic, in just regular annual visits with healthcare providers. And so I personally want to thank you and all of the work that the research teams are doing to build this. Just a little history. How long has it been that you've been working on these biomarkers? Like, I feel like I've heard about blood-based biomarkers for a number of years now, but I can't say if it's been 10 years or over 10 years, or like, how long have you been doing this work?
Yeah, it's well, we've been doing this amyloid PET scanning imaging since 2009. And it's just now starting to really speak volumes because we have that longitudinal data now.
Mm-hmm.
The blood tests they've been out there. People have been talking about them and developing them over the last 10 years, but they've really just gotten accurate in the last few years. Really, the last, I'd say, 3 or 4 years. They've gotten accurate to the point where we can start deploying these clinically. And there's one commercial test right now that is a blood test that can be ordered clinically at UW. And pretty soon there'll be others, but right now it's just this one test. It's called the C2N test. But these blood markers, that field is developing so rapidly. It's what we did 5 years ago or 10 years ago is going to just feel like ancient history 2 years from now, because things change so rapidly. There was a question in lacrosse, I think.
Yes, and I'm also going to invite Nate into the conversation as well. So the question out of lacrosse is, does aphasia always lead to Alzheimer's disease?
Great question. Aphasia is a progressive loss of function of language, and that could be language output, called production aphasia, or comprehending language, called receptive aphasia. Sometimes it is due to Alzheimer's disease if the proteins are kind of accumulating on one side of the brain in those language centers, which are usually, for most of us, on the left side of the brain, in our frontal lobe and in our temporal lobe. Yeah, it can be due to Alzheimer's, but it doesn't always have to be caused by Alzheimer's. More often, it's related to a stroke in that part of the brain. But there is this condition called primary progressive aphasia, which this person may be referring to, that is sometimes caused by Alzheimer's, and it's sometimes caused by other proteinopathies in the frontal temporal lobe family of disorders. So sometimes it's Alzheimer's, sometimes it's not. We need to do the biomarkers to really know which is which. Hope that helps. Sorry, it's not a clear answer.
Yes, thank you. I'm going to take another question from the chat, and then Richard, you'll be next, okay? The comments are: starting this diagnostic journey with my 89-year-old mom, MRI shows atropic changes. Should I push for biomarkers through her provider? Has Medicare been covering these blood tests?
That's a great question. I think yes, you should get her in front of the provider, and the provider can order the right tests. I think you can encourage the provider to ask for Alzheimer biomarkers. Yeah, if that's going to impact whether your mom gets on treatment or not, then it would be important to know if it's caused by amyloid. Medicare is not covering these blood tests yet. They're too new. Nate may have more information than I do, but I don't think they're being covered at all at this point. But that will change as the medical field gets more experience and confidence in these blood tests.
And I would also add that, even before we get to the biomarker, which I think is really important for just personal meaning of what exactly is happening in my brain, you want to know your diagnosis. And so you want to know, do I have mild cognitive impairment? Do I have dementia? If I have dementia, what stage am I in? What do my scores look like on thinking tests? What are other factors that could be affecting my thinking ability? Could I have sleep apnea? Could I have a vitamin deficiency? And Dr. Przybelski is on the call now, and he'll talk to you about one of his more recent publications about vitamin deficiencies. And so you still want to know holistically, what are the things going on? And then I do think talking to your provider about, well, there are these newer tests that look for amyloid protein, and that could be an important signifier that Alzheimer's is present. And even if you decide, or you're not eligible for the therapy that Dr. Przybelski will talk about next, I still think that a person may want to know that, because we are all curious creatures, and it might provide meaning as to your experience. It's better to know. Well, some people would say it's better to know than it is to not know. And that is an option. You don't have to know, but you certainly want your provider to diagnose you with that syndrome first, and help show you on thinking tests where you're having objective changes in your brain's ability. So you absolutely should talk to your provider and get a referral. We have resources here about the Wisconsin Alzheimer's Institute and the memory clinics that are scattered throughout Wisconsin. And so there are hopefully providers within driving distance, possibly a couple of hours, but within driving distance of you.
Thank you both.
I'm just wondering, I guess my main concern is if we find out that lecanemab and maybe eventually other medications are effective before the symptoms are at onset, how is that going to be funded? Because it seems like the government is taking a position pretty strongly against any kind of I don't know, especially costly treatments regarding early Alzheimer's, and like, what can we do to try to influence the government along these lines?
The main thing is it's a great question. The main thing is to get the data from studies, and data and empirical evidence is what we need to convince the government and Medicare and insurance companies to cover this. We also need, so the AHEAD study is something everybody is watching, and there's other prevention studies happening now with donanemab. There's another study called Trailblazer 3 that is using donanemab, and UW is not doing that study, I don't think, but it's nevertheless an important trial we're all watching. If we can show we being the royal we as a field that we can prevent symptoms and slow them down, then we'll be in a position to convince Medicare and FDA and insurance providers to cover this stuff. And then, we envision one day, hopefully not in the too far distant future, that there'll be screening for Alzheimer's proteins in the clinic. And then we can put people on prevention therapy prophylactically, so to speak, and avoid those symptoms from ever occurring in the first place. But we're still a ways off from there. There's a lot of work that has to happen, including this really important study, the AHEAD study.
Thank you. We've got about 5 minutes left for this portion of the Q&A. I want to make sure we get to the question from an individual that's taking part in today's program from La Crosse. So Kelsey, would you be able to unmute and?
Yep, you can hear me?
Yes.
Okay. My question is, it's interesting to me, the blood tests that you've been talking about, that's just interesting. But from a practical standpoint, people who are going through this mainly interact with that questionnaire, or what is it, 20 questions or whatever it is, and that you could score and so forth. I personally, and also people I talk to, pretty much all of us are critical of that test. And so I'm surprised that that isn't something that at UW is being investigated to re-examine that test. It works for some people maybe, and some people it's just useless. So it just seems to me it would be practical to look into that test to give yourself another tool.
Yeah, you're so right. These cognitive tests that we use, they tend to be biased. People with higher education tend to do well on them. And if you get them over time, repeatedly, you know what the items are and you become a professional test taker. And so cognitive tests are only as good as they're constructed and only as good as the study design. In some of our longitudinal studies, we deliberately choose to give the same thing over and over. We factor in practice effect, and a lack of a practice effect is usually informative for us. But it is a limitation of using cognitive tests, which is why we need to boost that by having these biomarker tests. The blood test, the CSF tests, the imaging tests are really the way of understanding whether this disease is present or not.
Okay, we're going to try to sneak in 2 more questions for you, Dr. Johnson. The first one is, I'm curious if your research mirrors the findings of the Buck Institute, which suggests multiple causes of AD besides amyloid plaques.
Yeah, I think that's the concept is the same. I think some people in our field have different definitions of what they call Alzheimer's disease. Today, I've used what we're calling the biological definition, which is what the neuropathologist uses. There's plaques and there's tangles. And if a person has those 2 things, they have Alzheimer's disease. What the Buck Institute found is that, is what many in our field have also found, that there's other causes besides plaques and tangles that contribute to the clinical picture. It might look like Alzheimer's disease. It might be a memory predominant cognitive pattern that's progressive, but it could be due to Alzheimer's plus something else. And I mentioned a few of those possibilities. One is this protein called TDP-43, which accumulates in the hippocampus, the same area that is involved in Alzheimer's. Another one is called alpha-synuclein, also accumulates near the hippocampus in a place called the amygdala, right next to it. And so, yes, these things can co-occur, and they give rise to the dementia syndrome that we usually call Alzheimer's disease. But in fact, it's dementia due to multiple factors. I know it's a little confusing, but That's why we need these biomarkers, so that we can tease these things apart and understand how much Alzheimer's is contributing to a person's symptoms and how much these other proteinopathies are contributing to it. That'll be the
Thank
big focus
you.
of our clarity study over
Yeah.
the next few years.
So we're going to take one more question. There's a question in the chat about lifestyle and health factors. I'm going to save that one for a little bit later in today's program. But we have one person with their hand up.
Hello, I have a question about attention deficit disorder as being part of this. Can you address that, Dr. Johnson?
Sure. Yeah. Attention deficit disorder is it's something that has a kind of the definition and identifying that syndrome is in the hands of the provider and in your subjective experience. And it can be part of the syndrome of Alzheimer's disease that a person has deficits in attention. It also can be part of some of these other syndromes that we're starting to talk about, like Lewy body disease or something else, but it's usually not the primary feature. And I think it really does require somebody like Dr. Chin here, or Dr. Przybelski, to really take a close look at that and figure out what the cause is. Often it's medication, often it can be mood related or anxiety related things. It doesn't necessarily it's not necessarily related to Alzheimer's disease or any of these other proteinopathies. It could be part of the presentation, but that would be unusual for that to be the most common and the most salient, the most vivid part of a person's Alzheimer's disease. It's usually memory or something else rather than attention. Nate, did I get that right? I'll defer to the doctor.
No, it's a really great question. And I will say, when people come to our memory clinic already with a diagnosis of ADD or ADHD, this is the reason a memory clinic like ours has a neuropsychologist, a clinical neuropsychologist, so that they can really consider that history and the known changes that happen in that condition as they are taking thinking tests, because there is overlap in the experience and sometimes even in parts of the performance on thinking tests, but they are able to try to discern some of those differences as we think about what Alzheimer's disease changes look like versus changes that are reflective of ADHD. So we do still think of them as two separate entities, but with similar symptoms, some similar findings on thinking tests. But that is the reason why we absolutely in our clinic have neuropsychologists who pick certain tests, thinking tests, to help figure out if symptoms are related to ADHD or if they're related to some sort of brain process like Alzheimer's. I mean, it's not easy, and it's certainly not something that, just by talking to someone we would know, which is why the biology is so important, why thorough thinking tests are so important.
And what about blood work?
And that would be the blood work piece of it that Dr. Johnson's speaking to.
Okay.
Dr. Johnson, thank you so much for taking a little time out of what I know is a very busy schedule that you have. We really appreciate you sharing this cutting edge research that is being done. And I'm really proud that this is happening right here in Wisconsin. So thank you for all that you do.
Thank you. Appreciate that. It's been a pleasure to be here today.
All right, so I'd now like to introduce you to our next guest speaker, Dr. Robert Przybelski. Dr. Przybelski is a faculty member in the Division of Geriatrics and Gerontology with the Department of Medicine at UW-Madison. He has received many local and national awards for his clinical and educational works, and is world-renowned for his pioneering clinical research with artificial blood. He is the director of Geriatric Memory Clinics and is involved in a number of memory research efforts. He also trains fellow, resident, and medical students from multiple disciplines to diagnose and treat dementia, and directs their research efforts in vitamin deficiencies and sleep apnea. Dr. Przybelski's clinic focus is on memory assessment and treatment. His research interests include vitamin deficiencies causing memory problems, neuroimaging with metabolic, amyloid, and tau PET scans, and sleep apnea effects on memory testing. So thank you, Dr. Przybelski, for joining us today. I'm really happy to be able to have you on as one of our guest speakers, and I'm going to hand it off to you so you can get started.
Great. Thanks, Jen. It's nice to be here, especially after listening to Dr. Johnson's talk. It's a good follow-up, I'm sure. So basically, I always like to start my talks with reminding everyone about Alois Alzheimer, who's shown on the far left. Basically, he is the one 100 or so years ago who first defined Alzheimer's disease with a patient for Augusta D, who he took care of for a period of time. And then when she died, he obtained her brain and did the pathology and described in his drawings the amyloid plaques you see in those brown spots and the neurofibrillary tangles, which are within the cell, causing disruption of neuronal function. And basically, he was not the first one to show these plaques and tangles. Actually, they were seen maybe years before by his colleagues, but he was the first one to show these plaques and tangles in a young person, because Frau Augusta was only in her 50s at the time. And that's how he defined his Alzheimer's disease. After that, over the next 50, 75 years, it was debated whether everyone with plaques and tangles had Alzheimer's disease or did they have senile dementia. And finally, in the late 1970s, it was decided that everyone with plaques and tangles had Alzheimer's disease. So for the longest time, we clinicians, Dr. Chin, myself, and the clinicians who diagnose patients, typically would use something called the DSM, the Diagnosis and Statistics Manual Criteria for Alzheimer's Disease. This is the latest manual, showing that the criteria for Alzheimer's disease included a gradual onset, one or more abilities, no evidence of other conditions like stroke or other conditions that could cause it. They recommended replacing the word dementia, which is kind of vague. It doesn't really tell us anything, with other terms like mild or major neurocognitive disorders. The major would be the 2 or more abilities. And as Dr. Johnson said, that would typically affect independence, whereas mild would be patients could still be dependent. And they recommended, actually, this is back in 2013, that we use biomarkers for the diagnosis. And this is, again, what Dr. Johnson just showed you. There's a normal decline with aging, and then there's the more rapid decline in cognitive abilities or functional abilities with patients with Alzheimer's disease. And the major is a later stage, and the mild is the early stage, mild neurocognitive disorders or mild cognitive impairment. So basically, we in the clinical side had the definitions I just showed you, which means we were trying to make a diagnosis of Alzheimer's disease on clinical presentation, which is very, very hard. And this is one thing I want to really establish for the viewers out there, is it is not an easy diagnosis to make. It really is not, for all the reasons that Dr. Johnson mentioned, and also the questions that were brought up, showing that it can be very confusing with aphasia and the various symptoms. So while I'm working the clinical side, and at times also about 40% of my work is on the research side, when I would interact with my research colleagues, they would refer to these diagnostic criteria from the National Institute of Aging and Alzheimer's Association, NIAAA, is basically being based on, as Dr. Johnson mentioned, biological criteria. What I would point out is they mentioned that there are 3 biomarkers, as Dr. Johnson mentioned, amyloid, tau, and neurodegeneration, that we should be using for the biologic diagnosis. And finally, this is what's really exciting to me, finally in the draft criteria that will be coming out this year in full force, the 2024 criteria for Alzheimer's disease will now be for clinical also, and it will basically emphasize that you need the biomarkers to make the diagnosis. And what's really interesting, when the final criteria come out as they should based on the draft, it will say if you have amyloid in your brain, you have Alzheimer's disease. And that doesn't mean the normal level of amyloid, but an elevated level, as Dr. Johnson was mentioning. And what that means is that for the first time, we can make a diagnosis of Alzheimer's disease in the preclinical or prodromal time. And that's the time that we really want to get to it and stop the disease process. So I'm so excited that finally we have affirmation that the biologic criteria and the clinical criteria are coming together. And as I'll indicate in a little while, that has a big clinical impact. When you look at the development of Alzheimer's disease, there's something called the Jack curve. And what's important is that first curve, or the earliest part of presentation of Alzheimer's, is with that amyloid increase. The second part is with what's called synaptic density, or the loss of the synapses, the parts of the nervous system that communicates to each other, the nerve synapses. And basically, with information on those two components, we can make a very accurate diagnosis. Historically, we use the MRI, as Dr. Johnson mentioned, and typically, if you look at the top left, you see a normal healthy hippocampi, and then down on the far right, the bottom right, you see a shrunken or atrophic hippocampi. And that's what we had as a biomarker. And back you see 2004, that was pretty much it, short of autopsy. But in 2004, 2005, the Medicare actually approved another test, a test called the metabolic PET scan, which I've been using since 2008. What this shows is a biomarker, is a picture of the right side of the brain on the top left in your picture, the left side of the brain top right, and then the middle of the brain down below, left and right. And those areas that are bright yellow, red, and green are the areas that are affected by Alzheimer's disease. And we know that because when these patients with these scans were taken to autopsy, the necrosis, the dead part of the brain or dying part of the brain, would correlate with those parts that lit up because those were not consuming the glucose that was injected properly. And in fact, in the lower scans, the lower pictures, the parts of the brain most affected and earliest are called the posterior cingulate, which are inside the brain, which are close to the memory areas. So basically in this one scan, type of scan that is, again, paid for by Medicare, we can get biologic evidence or biomarker evidence of Alzheimer's disease. In fact, the two biomarkers would be the necrosis and the tau. So one scan approved by Medicare can get two of the three biomarkers that I just mentioned. In fact, I can see Alzheimer's disease very early in patients with this scan. This was a negative, it was read by the radiologist as negative, but in the lower scans, those bright spots that I'm pointing to now, can you see my arrows okay, Jennifer? Can you see the arrows? Yeah. Can you have a look? Can you see do you see my arrows pointing? No? Okay.
I
Well, anyway, in
don't,
the
I'm
lower
sorry.
scans, where there's a little bit of green and yellow in the lower scans, that's the earliest findings of Alzheimer's disease. And in fact, if you look 2 years later in the same person, now the bright spots show up more typical of Alzheimer's. So again, this scan, this is not a research scan, this is a clinical scan that can be obtained at any center that does cancer work or cancer imaging, because this is basically the same test as a glucose PET scan. So anyway, this can be very, very helpful. And when we're getting these scans, when I'm getting these scans, sometimes it shows other conditions that Dr. Johnson was just talking about. For example, in this scan, you see the bright areas along in the upper parts, especially in the left, what's called the temporal area, which is the red and yellow area that's brightest. That's associated with speech. And in the lower areas, or the frontal part of the brain, you can actually see areas that aren't working well either, which are causing behavior problems. So in fact, this is a scan of somebody with frontal temporal disease, which is again very helpful. And here's a scan of somebody who actually has Lewy body disease. And we know that because it's affecting the back of the brain. And that typically is not affected by Alzheimer's, at least not in this pattern. So basically with this scan, which is a clinical scan, which can be obtained in many places, we can pretty accurately diagnose Alzheimer's disease, Lewy body disease, frontal temporal disease. So it's very exciting because we have these biomarkers in clinical use. Dr. Johnson mentioned the spinal fluid. This is what we get, what we send spinal fluid off to Mayo Clinic for analysis. Is that star in the bottom or the asterix in the bottom shows us where the levels of amyloid and tau would be in a person with Alzheimer's. So spinal fluid also can provide information on amyloid and tau. And many of my neurology colleagues use spinal fluid because they use it for a lot of conditions. So here's a scan that we obtained, and Dr. Chin and I actually obtained when we were doing a study in 2017 and 2018, looking at for amyloid in the brain. And basically, this is a negative scan because all the brain is yellow, is green, blue, and a little bit of yellow. The red that's down in the middle part is the normal part that would have amyloid. And this is as opposed to an amyloid scan that we see here, where everything is red because amyloid is typically deposited all over the brain, as opposed to tau, which can be more localized. So there are these two scans, which when Dr. Chin and I did this, Medicare was not paying for it. In fact, only in the last few months did Medicare start paying for it, actually in July of 2023, so a while back. But nonetheless, we can now obtain this scan clinically. We can get amyloid scan. Dr. Johnson brought up the blood tests and the fact that, in fact, they can be obtained clinically. A company called C2N, that's capital C, 2, and then N, is actually producing a blood test that we are using clinically. The exciting thing for us is it actually was co-developed here at the University of Wisconsin with our patients in Dr. Johnson's lab, which is very accurate. It uses the age of the patient, the genetic status of the patient, along with the amount of amyloid measured in the blood. It's not reimbursed by Medicare currently, but the company has been very generous. The typical cost of the test is $1,500. Most of my patients, because of patient assistance, can get it for less than $400. And actually, this can be obtained. It's in our laboratory, we can, but actually, C2N has a way of obtaining these blood tests at other places also, besides laboratories that have them. In fact, when they started doing this last year or so, I think they even had groups that would collect blood at the home, but the primary doctor would have to order it. So anyway, you could ask your doctor to look into the Passivity AD test for diagnosing amyloid in the brain and possibly Alzheimer's disease. And what it looks like when you get the results is this, is they have on the far left, you have a person with negative scan blood test, and on the far right, where you see the red line for one of my patients, that was a positive test. So it correlates very well with the amyloid scans that Dr. Johnson was showing you and the one I just showed you. So now the main reason I wanted to talk today, or happy to talk, is to tell you about the treatments. And I like to break this down into the good, the bad, and the difficult. The good is that, first of all, we've had treatments for symptomatic memory problems in Alzheimer's disease for about 30 years now. Some of you could very well be on the medicines, donepezil, rivastigmine, or galantamine. Tacrolimus, which was the first, is gone because it had too many side effects. Basically, what these medications do is they increase the neurotransmitter called acetylcholine, which is how your neurons communicate to each other. And basically, it helps the brain function better. And this works for Alzheimer's disease, but it also works for other conditions, even patients with vascular disease. And then there's another one called memantine, which works totally differently. People say it reduces or increases the signal to noise ratio. In other words, it helps focus the activity of the brain more on the memory. So they're a good combination. In fact, that's how they pretty much should be used. This fancy slide is just showing you what the monoclonal antibodies or the new agents do. Is basically where you see those brown spots, that depicts the amyloid plaques in the brain, which the monoclonal antibodies or these treatments remove, but also they can bind up the amyloid as it's floating around, causing damage to the brain cells even before they form plaques. So that's what the monoclonal antibodies can do. The first one, which I've been used for about two and a half years, I still have some patients being treated, was produced by Biogen, and it was called aduhelm or aducanumab. And this was approved by the FDA in 2021 by an accelerated pathway. It was the first new medication since 2003. It was indicated for Alzheimer's disease in a mild cognitive impairment or mild dementia stage of the disease. It was based on removal of plaques because that's what these products do. Medicare refused to pay for it. And sadly, it was removed from the market in February of this year. Like I say, I still have patients on it, but they're getting it through patient assistance of the company. I say sadly because it removed amyloid from the brain. It removes amyloid from the brain. I felt very comfortable using it. It's once a month, but Medicare never agreed to pay for it. Just to show you that I've had a number of patients, about 200 infusions to date, didn't have any infusion reactions. Lecanemab, which is the new medication, the medication we're using currently, was approved by the FDA in 2023 via the regular pathway. It was approved by Medicare reimbursement in 2023 in July. Indicated also for mild cognitive impairment and mild dementia stage. It was approved just as aduhelm was on basis of removal of amyloid plaques, which it does. And we're hoping, keep my fingers crossed, our fingers crossed, that there could be an injectable form later this year. So we treated our first lecanemab patient, gentleman who was 82 years old that I had followed for about 7 years. He was in a mild stage of the disease. We made sure his blood pressure, cholesterol, vitamins were all in good shape. He was a gentleman who was walking, exercising at least 30 minutes a day. He was on a good diet. He was also on memantine, not on anticoagulants, which is a contraindication for some of these products. He was on no supplements except for B6, which is very important. And he had screening changes with just a mild vascular. So this is the first patient I treated, which actually was a month before the product was approved by Medicare, and reputedly the first person in the country who was treated in a clinical setting. Donanemab is a product that's coming soon. You may have heard it was delayed in its approval, but it's pretty much a technicality. It probably will be approved in the next 2 to 3 months after they have an advisory panel meeting. So basically, the phase 3 study, the study with donanemab, is a little bit different than one with lecanemab, in that they broadened it a little bit, and actually we can take people a little bit later in the disease process. That's the 20 to 28 on the mini-mental state. It also was shown to significantly slow cognitive and functional decline, just like lecanemab did. What's a little different from the donanemab is it seems to be a little more active or aggressive, in that 71% of patients actually clear by 12 months instead of 18 months of treatment. And they also looked at tau levels, which the other studies really didn't, the other products. And the patients basically with earlier in the disease, less tau actually do better, which is not a surprise. So that's the good. The good is that these products clearly remove amyloid from the brain, and they seem to have an impact on the progress of the disease. They do not stop Alzheimer's disease. They do not make the memory better. Damage that's there is there, but the idea is to slow the progress of the disease. The bad is that there's something called amyloid-related imaging abnormalities, which are microhemorrhages and edema in the brain. If people have 2 copies of that gene that Dr. Sterling mentioned, the APOE4 gene, basically they're too high of a risk for us to treat. And therefore we have to do the genotyping to find out if it's safe to treat people with these conditions. The incidence in the aducanumab, the first product, is shown here. 35% of the edema, 21% of the hemorrhage or microhemorrhage. Lecanemab was 13%, 17%, so there's a reduction. And donanemab, higher again, more likely aducanumab, but as I mentioned, it's probably a more active or aggressive product. Here's a picture of one of my patients with one of the ARIA. You can see it in the white spots in the back. That resolved after 2 or 3 months because we follow them to make sure it does. So other adverse effects. And when I tell patients about these products, I make sure they understand that besides the microhemorrhages and edema, there can be even more serious side effects, as in strokes and death. These are very, very rare, less than 0.1%, but nonetheless, I want my patients to know that there are trade-offs and there are risks in having these treatments. Besides the strokes and deaths, there are seizures reported with aducanumab and lecanemab on rare occasions. Also, infusion reactions. When patients get, especially the first couple of infusions with lecanemab, they can have 1/4 of the patients can have a reaction like an allergic reaction, usually mild, but it still could be a reaction. So that's the good is they definitely work. They definitely remove amyloid, which, as Dr. Johnson pointed out, is critical for Alzheimer's disease. They do slow the course of the disease, which that's what most of us would want if we have Alzheimer's disease, is to at least slow the course if you can't stop it. But they do have potential side effects. And the difficult part, and this is where it really gets into the problem with treating patients, is there are a lot of things that have to be done to prepare a patient. I'm not going to go through this. I'm just saying these are the type of criteria that we have to go through to try to make sure a patient is capable or we can undergo the treatment. And also we have to look when we do the brain scans before we start, we have to look for that white matter disease or the vascular disease that Dr. Johnson mentioned, showing here in the fluffy white material in this brain scan, and also showing here in the holes, basically holes in the brain, something called cerebral amyloid angiopathy. So we have to make sure people don't have these conditions before we even start. So when we prepare a patient for treatment, it takes a lot of work. It takes usually 3 visits, probably 30 to 45 minutes each. I go through all the medication side effects, the sheets that were approved by the FDA. I make sure over and over that everyone understands that there is a possibility of stroke and death besides the side effects, the more common side effects. I make sure that these patients have a good possibility of responding to the treatment as well as a low likelihood of side effects. And therefore, we screen for sleep apnea, we screen for seizures, we screen for vitamin deficiencies with blood tests, which are very important, as Dr. Chin was mentioning. Make sure the blood pressure, cholesterol, thyroid, blood sugars, sleep are all in order. And sometimes most importantly is treat their polypharmacy, which means if there are any medications we can get rid of, try to get rid of those because they're going to complicate the treatment and make it difficult to know if the patients are doing well or better. Interesting, I put supplement discontinuation. A lot of the supplements people are on can actually cause bleeding or cause side effects that could complicate our treatment. So typically, I would want patients to stop their supplements unless they're vitamins that were prescribed by their doctor. So basically, optimizing the patient. Before they start, I say, okay, I'm not going to treat you unless you're doing these things because these are very important for your response to the treatment and safety. And that is, I want people to be exercising 20, 30, or 30 minutes each day. It can be walking, it can be a stationary bike, and any other easy aerobic activity. I want them to do brain exercise with fun and easy brain puzzles, word and picture puzzles. There's something called the MIND diet, which is based on the Mediterranean diet, which is a very healthful diet and prevent vascular disease. And lastly, I want them to have a really good attitude because this was shown a long time ago by one of our geriatrics colleagues that when patients go into a procedure like a surgical procedure, the greatest determinant of the outcome is what their attitude is going in. In other words, if they feel they're going to have a good response, they're not going to have any significant problems, and they're going to be happy with the result, that determined typically that people were going to do well. So I wanted people to come in, if they're going to be treated, they're going to say, yep, we're going to do well. You know, I'm going to tolerate this well. I'm going to hopefully benefit from this study. They work. And if it's not there, we just have to sort of say, well, think about it a little bit more. One of the things we do here, which we encourage other clinicians to do, is really screen for seizures because seizures are very common in Alzheimer's disease and can complicate therapy. But getting into the more difficult and critical paths in treating patients is, for us here in Madison anyway, is finding an infusion center. Even though I've been treating people now for almost 3 years, but we still have difficulty finding infusion centers because Medicare does not reimburse well for Alzheimer's patients and for these treatments. In fact, as you can see, the second part of that, we're sending patients to all over the place, including Iowa and Michigan and even Illinois. So basically, it's hard sometimes to find an infusion center that will treat patients with the lecanemab. And actually, we have patients that travel to Florida and other places, and that's also difficult to set up if they're going to travel. So once we find a patient to treat we want to get on infusions on lecanemab, that is the problem with the infusion centers. And once we start treating the patients, we have to follow them very carefully to make sure they don't have the side effects of those microhemorrhages and edema that I mentioned. And that means doing MRIs, brain scans, every few months. This is actually the protocol we use for Aduhelm. The lecanemab is very much the same to that. And it's just hard to get that many MRIs, both for the patient and for the clinician to set them up. So that's where we are today, is basically we have treatments, they do work. We can diagnose the disease early on and interact with, hopefully get people started early. But perhaps the most exciting thing is what's coming soon. And Dr. Johnson mentioned the tau scans. Tau imaging is around the corner. The agents are approved by the FDA. They still need to be approved by Medicare. There will be better therapies, less toxic monoclonal antibodies, better focus on the target, less damage. The subcutaneous forms, as I mentioned, in other words, injectable. We're hoping that lecanemab, the one we're using now, will be an injectable form that patients will give themselves at home, hopefully in this next year sometime. There will be anti-tau agents that will actually get rid of the tau, and then we can treat not only Alzheimer's, but frontal temporal disease and other conditions like supranuclear palsy, which are very devastating. Alpha-synuclein agents, again, Dr. Johnson mentioned that that's a protein that's often associated with Alzheimer's patients, along with the Lewy body and Parkinson's disease. And then this is probably the most exciting thing, and I really try to make this a point, is that by combining some of these therapies, like the anti-amyloid and anti-tau, we are going to be able to put Alzheimer's disease into remission, just like cancer patients are put into remission from their cancers. So even if we can't cure a patient now of Alzheimer's, I believe we can stop the disease, and we will be able to do that in the next 5 to 10 years if things continue to progress as they are. Finally, we may be able to combine the various treatments for an actual cure of Alzheimer's. That won't be quite as soon, certainly, as putting it in remission, but I believe it's a possibility. And now we're not talking 50 years, we're talking the next probably 10 years, 5 to 10 years. So what else? Well, this gets even more exciting. There was an anti-amyloid vaccine that was developed in 2001, and 372 patients went through the treatment, and it turned out that they would induce platelet antibodies to the plaque. But unfortunately, of 87 patients initially treated, 6 of those developed encephalitis, which is an inflammation. None of them died from that condition. But what was interesting is when these patients in the study would later be taken to autopsy, dying from other causes, it turned out that the vaccine worked. And again, this is a vaccine back in 2000 for amyloid, actually worked. It just caused too much of a reaction, and maybe they weren't even sure if they were the right patients at that time. They may have been the E4, may have been more risky. In any case, we're finding the regular vaccines that we're getting for other conditions like tetanus, for herpes, for pneumococcal vaccines. Actually, patients who get those vaccines have less Alzheimer's disease. I mean, isn't that amazing that just vaccines in general might be able to induce to boost your immune system such that your body can handle Alzheimer's or the amyloid or tau. So, I mean, that's really exciting just to know that vaccines in general may help reduce the incidence of Alzheimer's disease. And again, puts emphasis on the fact that we can develop vaccines that can hopefully stop or prevent Alzheimer's. In fact, currently there are vaccines in the making. There's one against A beta 42 or amyloid in brain. It's also being tested in Down syndrome, which I'm really excited about because we're up to this point, Down's patients who virtually all get Alzheimer's are never included in studies. And also there's a tau vaccine, which really looks exciting. I've seen evidence on that. And that's in the process too. So just imagine that, as Dr. Johnson was showing you, that we can detect amyloid early on, and then patients who are developing amyloid could potentially get the vaccines and stop the disease from ever developing in the first place. We are not far away. And that's what I want to pass on to you. We are not far away from that. So basically, in summary, the monoclonal antibodies we have now remove amyloid from the brain. The FDA considers these treatments as disease-modifying therapies, and that is a big deal. Just like rheumatoid arthritis used to devastate people and they couldn't function after a certain amount of time, and now they can get all those treatments you see advertised on TV. We are not far from that. Putting these patients into remission, putting Alzheimer's patients in remission is possible in the not too distant future. Vaccine to induce immunity, active immunity to prevent Alzheimer's in the first place is possible. And just to highlight the fact that we are in our clinical program, just as in the research program, we're at the forefront of Alzheimer's diagnosis and management. Thank you.
Oh, wow, Dr. Przybelski, that was a lot of information that you were very succinct in being able to share in such a short period of time, and really is hopeful. And so I'm so glad that you were able to join us and share this information. We have a few minutes for some questions, and so I'd like to we'd like to get started if that's okay. Let's see. I want to go back to a question that has been out there since Dr. Johnson's presentation. So that question is, what are the key lifestyle and health factors contributing to resistance? And I think, yeah.
That's great. Should I go into it?
Yep.
Yeah. Number one is always exercise. Over and over again, exercise, physical exercise, walking, stationary bike, that type of thing. That's if I can get my patients to do one thing, it's the exercising every single day. And that's not huffing and puffing, it's not hurting, it's not that type of thing. Find something that you can do routinely and start doing it and try to do it every single day. So that's number one. Number two, I would say would be brain exercise, doing crossword, jigsaw, cards, playing games. My rule of thumb is the easier and more fun it is, the better it is for the brain. You launch into a New York Times crossword puzzle, Thursday edition, whatever, and gets frustrated, that's not going to do you any good at all. Find a fun and easy book, the kind of things we did when we were kids. In fact, I say, hey, what did you do when you were 10 years old and your brain was developing? You played games, you played Monopoly, you read stories that were fun and easy. You read out loud, which you did at school. All those things actually can make new connections in the brain. Nutrition, following the MIND diet or the Mediterranean diet, which helps the vascular disease as well as helps the brain to impair brain function, can be very helpful. Social activities, more and more social activities are very important. Going to the senior center, interacting with your friends, that's good. There's more information on music. Playing music an hour a day, listening to music you love to listen to even when you were a teenager or a kid, can be really, really helpful for the brain. So those 5 things all by themselves can help the memory and help theoretically prevent Alzheimer's disease or mitigate that. So good. Any other questions?
Yes, they are starting to come in. So I believe we have another question out of the gathering in La Crosse. Kelsey, do you want to unmute yourself and
question, or if you could confirm on the medicine Lequemba, I don't know how to pronounce it exactly. You answered part of it saying that one of the downfalls was, excuse me, finding the infusion center and that there weren't very many of them. Can you also address the cost and how that is given. I believe it's an infusion that's given every 2 weeks.
Yes.
Yeah, that's correct. It's an infusion that's given every 2 weeks now. Again, hopefully that will transition to the subcutaneous that will be given actually twice a week. The injections would be more frequent, but could be done at home. The cost Medicare pays for Leqembi, that's lecanemab or Leqembi. The infusion center cost of, again, the treatment itself is typically covered by Medicare. The insurance companies is a bigger question, especially the Advantage plans. We're having a difficult time with that coverage. But basically, the imaging, the infusion center, and the treatment drug should be covered by Medicare.
Thank you. We have another question that's, could you expand on what the MIND diet is?
Yeah, it's a version of the Mediterranean diet that was actually tested in clinical studies 5 to 10 years ago, showing that patients on this diet, which was basically, again, like the Mediterranean diet, emphasizes fruits, vegetables, non-red meat, non-processed foods, that type of thing. It actually included a glass of red wine, I believe, in the original diet. Basically, what the MIND diet says is do more of these. And then the other section, which it says do less of these, which is basically cheese and fatty foods, processed foods, that type of thing. I like it actually because I got it on my refrigerator, because it's not one of those diets that says, oh, you got to eat this and you can't eat that. It says more of this and less of that, which is relatively easy to follow because I like a little cheese every now and then and some things. So basically, if you Google MIND, M-I-N-D, diet, you'll see that. And again, it's very easy to follow.
Thank you. I also want to invite Nate into the Q&A as well with you, Dr. Przybelski. We had a question come through when folks registered for today's program, and one of them is, when someone is showing early signs of MCI, how important is it to see a neurologist to determine what type of dementia a person has? Will identifying a type of dementia determine how quickly MCI may advance?
I'll take the first stab at that, Nate, if you don't mind. Yeah, it's important. It doesn't require a neurologist, actually. A family physician, a geriatrician, internal medicine can determine, starting with an MRI, to find out, just a plain MRI, not even with contrast, just to find out how much vascular disease there is. And that's really important because most of the time, especially as we get older, there is a component of vascular disease, and it can look just like Alzheimer's. And vascular disease is much easier to treat in terms of the life factors and so forth. Also, vitamin deficiencies, which Dr. Chin mentioned earlier that I've kind of into, is especially the vitamins, not only vitamin B12, which we hear about, but vitamins B6 and vitamin D are very important for memory. In fact, the study that we just published a few weeks ago showed that if you have a B6 or D deficiency, you have a 10% drop in your memory function just by having that vitamin deficiency. And those tests can be checked, those levels can be checked in your doctor's office. Sadly, they are not checked now. They are not the two vitamins, B6 and D, which are most important, are not checked, while B12, which does not appear to be as important, is checked routinely. So if you write this down and you want it checked out, have your doctors check your vitamin B6 and your vitamin D levels if you have memory problems, because that's a easily reversible cause of memory problems.
I feel like we may want to have you come back again in the future to talk specifically about the vitamin deficiencies and sleep apnea and how those could contribute to
Yeah, I'd love to.
cognitive changes. Those things are important to me personally, as I've got family members that have those issues going on right now.
Yeah.
There's another question from registration. A few of our friends are demonstrating signs of mild cognitive impairment. How best can we guide, advise, and support them as we are now in this older cohort that 85 plus age range, where these concerns, the percentages are increasing for risk.
I'm sorry, what's the question part of that?
The question is, how can we best guide, support, and advise friends and family when they're experiencing changes with their memory?
Okay. Yeah, first of all, again, the lifestyles is the way to go. First of all, everybody, no matter what their state is, whether what the condition is if they do those things we talked about, the exercise, brain exercise, good diet, it's going to help them function better in any case. Then the evaluation, as we just talked about, going to see their doctor and family medicine internist, neurologist, and say, can you help us figure out what the problem is? Because it makes a difference as far as what medications we use and how aggressive we are in the treatment. So that's what I'd say. If the changes are occurring, that's important. And there's normal aging, but there's also more rapid changes, which again would typically be vascular or Alzheimer's or one of these other conditions.
Thank you. We've got about 3 more minutes left for our Q&A. We've got a few that came through in the chat. With the introduction of easier testing, the blood test, are there medical ethicists that provide direction prior to testing with relation to the effects on insurance, etc.?
Nate, do you want it? Dr. Chin?
Yeah, I put in a response, a written response there, and what I would say is that the field of disclosure or returning results to research participants has been going on for years, and there's a lot of medical ethicists, actually JD, so attorneys, as well as clinicians who have really looked at the implications of sharing not only ApoE, which of course is available now in direct-to-consumer tests, but also amyloid protein and looking at now tau protein. And so within research, these questions are being heavily scrutinized as to what the process and discussion should look like. When it translates to clinic, it's a bit different because each healthcare institution really is responsible for what they are testing, and then the providers what they are actually saying to patients. And so I can say at Wisconsin, these conversations and discussions are happening. Training happens with our staff and teams so that we are aware and are covering the things that are really important, such as insurance, such as even just self-stigma or societal stigma. But it really, in the clinical world, is going to depend on the institution as well as the provider specifically. So there may not be ethicists directly involved, although certainly the conversation of what is ethical comes up most of the time when discussing any type of new result that is being shared with patients.
Thank you. We just have one request here, Dr. Przybelski, if you wouldn't mind stop sharing your screen. Some folks would like to see you.
I'll try to do that if I can figure out how to do it.
Awesome.
I'm afraid I'm going to cut myself off the meeting if I do, but I'll try.
Oh,
Because I got,
yeah, don't press the X button.
okay, I will.
While he's doing that, Nate, we've got another question here. If the vaccine prevents the development of amyloid, will that also prevent tau, or are they separately developing conditions?
It's a great question. And actually, there are different forms of tau, and that's why there are different diseases that can result as because of the tau protein. But when we think about Alzheimer's disease, it is the amyloid that is inducing changes in this specific type of tau that Dr. Przybelski was referring to with those vaccines. And so the idea and the presumption right now is that yes, by preventing the buildup or ever abnormal level of amyloid, that there wouldn't be this conformational change leading to tau protein. Now that has to be studied, and that will be studied in these trials. But it does, yes, that is the theory behind it, that it is the presence of amyloid plus other mechanisms that are leading to that tau, that specific tau development. And so removing amyloid does seem to be an incredibly important part of that process, with the downstream effect of not having elevated amyloid or not having elevated tau.
I think
Thank
it's a good
you.
summary. Yeah.
We have time for one more question, and so Dr. Przybelski, I'd like to send this one to you first. You mentioned that you had to rule out vascular causes before pursuing these treatments. Does none of this apply if there is vascular MCI diagnosis?
Well, the vascular diagnosis depends on how much change there is in the brain, the white matter and any strokes and that type of thing. Because these medications can cause bleeding or microhemorrhages, we have to shy away from treatment with them if there is significant white matter disease. Now, I'll make a diagnosis of mild or vascular MCI with changes that are almost minimum in the brain, but enough that I can say it could very well affect your cognition. Some of these patients are still eligible for treatment. So it's kind of a decision point as far as how much vascular disease is. But typically, most clinicians, they would not diagnose vascular MCI unless there are strokes or significant white matter disease, which unfortunately would typically rule out the treatment.
Thank you. So I think we're going to have to wrap up our Q&A for now. We've got some additional information that we just want to share with everyone. Dr. Przybelski, I want to thank you so much for carving out a little bit of time to spend with us and share this really important information. I'm really thankful for all of the work that you do, and keep going.
Thank you. Thanks for having me.
Yeah. So Allie, could you share our closing slides?
You see that? Okay.
Yes, yes. So we just wanted to take a few moments to share information about another ADRC. So we've got the Alzheimer's Disease Research Center in Wisconsin, but we also have Aging and Disability Resource Centers. So the two entities are very different. And so we'd like to just take a little time. We have Rob from Dodge County, who is just going to share a little bit, just a couple minutes of information about what the Aging and Disability Resource Centers are and why you might want to consider connecting with them. So Rob, if you're on, would you mind unmuting and...
Yeah, thank you, Jennifer.
Yeah. Mhm.
So the Aging Disability Resource Centers are places that you can go, call, go onto their websites. Each county has one, and they are non-bias places where you can get information on all kinds of different resources. It is where people can go and apply for Medicaid. They can help with Medicare, with there's a disability specialist, an elder benefit specialist. There's resource specialists. Each county is represented by an ADRC or has an individual ADRC, and each of those Aging and Disability Resource Centers has a dementia care specialist that represents that county. And as dementia care specialists, we can work with individuals, with families, with the community, businesses, organizations to provide education, to provide resources, to help get things started in the community, or provide things like support groups, or social opportunities for people with dementia and their caregivers, like memory cafes, like spark groups, things like that, to make the communities more dementia friendly, more dementia inclusive, and to really help get things started. Because we can only do what we can do in our time. So really helping to be that catalyst to help programs get started, to help connect resources together. And lots of just really great programming going on. So if you're looking for things for yourself or for your loved one or for a friend, family member, I encourage you all to reach out to your local ADRC.
Thank you so much, Rob. I appreciate you taking a little time to share information about this additional ADRC. Next slide, Allie. I want to give you guys some information on some upcoming events. The Research Center has one of our signature events coming up in April on Saturday, April 6th. The Solomon Carter Fuller Brain Health Celebration will be taking place in Madison, and the keynote speaker is Dr. Lisa Barnes. Registration is open until March 21st, and so if you go to the link that is on the slide, and we can put that in the chat, and that will also be available when I send through the follow-up information after our program is over. We'll send that through to you via email. So consider attending that event taking place on April 6th. Our next Healthy Living with MCI program will take place on Friday, June 14th. We are almost ready to post that on our website, so keep an eye on that. Our guest speaker will be Dr. Adrienne Johnson, and she has been with us before. She's an excellent presenter, and she also she's a health psychologist, and so she is going to be talking about the topic of you are more than your diagnosis, and she's going to give us some information how to adapt to life if you are living with mild cognitive impairment. So I would highly encourage you to consider putting that on your calendar and joining us again in June. Next slide, please, Allie. Nate, I just want to hand this one off to you. Would you like to share with the group about the Dementia Matters podcast that you have been doing now for a number of years? Some really, really great topics that you bring forth in this particular outreach that we have at the Research Center.
I don't want to take up too much time. I just want people to know that this podcast with the website that you see there is a way for our center to translate some of the research happening, not only in Wisconsin, but with our colleagues across the country, where I interview researchers. We help explain what it is that they're looking at. There's some specific episodes related to caregiving or how to provide support for those with thinking changes. And then there are some topics like meeting with, interviewing Dr. Przybelski about lecanemab or some of the therapies that are hitting clinics. I will say right now we have one episode that's released, but we'll have 3 more where I interview research participants and they express their experience engaging in research, which has been a very important part of our program and understanding what this is like and how it can improve. So that has gotten a very positive response thus far, but we should have a new episode coming out in early April, and it comes out every other week. Or twice a month, I should say, on Tuesdays. And so please tune in if you have any interest. And the website does show all 180 episodes we've done in the past. So if you just click through, you might find something that you enjoy.
Awesome. Thank you, Dr. Chin. Another way to stay connected is to subscribe to our e-newsletter called Headlines. And so the link is in the slides. It'll be in the follow-up information that you receive, and it's also in the chat. So this is a great way to stay connected to the different happenings that are happening through the Research Center. We give little prevention tips that are really helpful, and a lot of people find those to be very pertinent information topics that they want to learn about. And then we would be remiss not to let you know how to volunteer for a study. If you are interested in learning about research that is happening here in Wisconsin at the Research Center, and you want to consider becoming a participant, a study participant, you can go to our volunteer study page, and there is a way to you fill out a form, and somebody from the Research Center will give you a call and explain more information. So we are at time 11:31. Dr. Chin, we've got a ton of information in this today in this program, and so we have ended almost on time. I want to thank everybody for taking part in today's program. Nate, do you want to say anything as we're closing out our time with everyone today?
Yes, just a couple of things real quick. One, thank you all for coming. The video will be released at some point in the very near future. Ben, there's a message from Ben with the link for that. Two, I really want to thank our Aging Disability Resource Centers. I call them the original ADRCs for participating in this and hosting. We very much appreciate that. And we are trying to form more of a relationship as well as support for such great work. As we know that really our ADRCs are providing frontline care for our communities, regardless if they have thinking changes or not. And the last thing I want you to know is it really is helpful to us if you fill out the surveys. The survey is going to help us understand who is coming to these events, why they're coming, what questions you have, but then also what is meaningful or not, and are we succeeding in our mission to provide resources and education. So please do fill those out. All right, that's the three things I wanted to mention.
Oh, thank you, Dr. Chen. And thank you to all of you who have spent the last 2 hours with us. We hope that this provided some informative information, and we look forward to seeing you again in June. Take care, enjoy your weekend, be well, and have a good day.